either similar or slightly worse outcomes, worse renal failure, longer length of stay with multivessel PCI. But with radial artery access with multivessel PCI, complete revascularization is advocated, and you have better outcomes. We could go back. So in patients with non-STACS multivessel disease, the mode of revascularization was one of the choices should be based on the disease complexity and comorbidities. It's now a class 1 lesion to open all their arteries, do complete revascularization. People do better if their myocardium is getting normal flow. And part of it is not just the stent technology has evolved, but also the adjunctive medications that we use. If you're doing multivessel PCI, this person had an FFR. It's reasonable to do FFR, QFR, or other assessment. I was OCT in some patients. While we advocate multivessel PCI for everybody with acute coronary syndrome, there's a select group of individuals, about 5% of patients who present with cardiogenic shock, when there is still worse outcomes. This is based on a very large study called Culprit and then subsequently smaller studies showing worse outcomes, and partly because their blood pressures are low, they don't handle contrast well. So that is one group of patients you should only do Culprit, but everybody else complete revascularization. Who needs CABG? It's really a select group, significant left main coronary stenosis with high complexity CAD, multivessel CAD with complex or diffuse CAD, diabetes and multivessel disease with involvement of the Bronx LAD, multivessel CAD or complex left main CAD or severe left main dysfunction. And the outcomes between PCI and CABG has changed. I think the studies from about 15 years ago showed mortality benefit in diabetics with CABG. Right now there's no mortality benefit, there's no MI benefit, but target vessel revascularization is still better with CABG somewhat, but comes at the price of an initial higher stroke rate with bypass surgery as people get put on bypass, on aortopulmonary bypass. Our individual syntax score was 6, which is considered low. As you know, any score less than 22 PCI is favored. Any score above 33 to 35 CABG is preferred. Between 22 and 33, we suggest talking to the patient PCP, the cardiologist, the interventionalist, as well as the surgeon. So the correct answer is to multivessel PCI. This person certainly was not in shock, and complete revascularization is now a class 1 indication and improves outcomes. You can do it either if you didn't use too much radiation, if you didn't use too much contrast. Often I'll do it during index procedure. Otherwise, typically I'll do it day 3 before they go home and send them home day 4 so that all the prior contrast has washed out. Again, take-home message, multivessel PCI is a class 1 indication because complete revascularization leads to better outcomes. The heart, once it's getting normal blood flow in all of the territories, tends to do better, less arrhythmia, less heart failure. What would be the optimal initial antiplatelet therapy in this patient? Should we treat him with aspirin plus ticagrelor, aspirin plus clopidogrel, or ticagrelor monotherapy, prasugrel monotherapy? Remember, he got multivessel PCI. And if we could get to the audience response one more time, please. We'll give 2 more seconds and then we can close. And again, majority of you got the right answer, aspirin plus ticagrelor. And if we can go back to the slides, please. So if you look at the guidelines, 2025 guidelines, PCI, aspirin plus ticagrelor or aspirin plus prasugrel for 12 months. Clopidogrel is recommended when ticagrelor or prasugrel are not available, cannot be tolerated. contraindicated for one reason or other. And this is based on better outcomes with aspirin plus ticagrelor or aspirin plus prasugrel compared to aspirin plus clopidogrel with minimal increase in bleeding. Similarly, in cabbage, you use aspirin plus ticagrelor or preferably or aspirin plus clopidogrel. Prasugrel was only tested in PCI patients, so it's not indicated in post-cabbage. If you're treated medically, aspirin plus ticagrelor. The one group of patients where clopidogrel is recommended is aspirin plus clopidogrel, though there is evolving data with even safety of ticagrelor and benefits in these patients. So again, you can use either aspirin plus ticagrelor or aspirin plus prasugrel. Aspirin plus prasugrel was not one of the choices, so the correct answer is aspirin plus ticagrelor, and it's recommended for typically 12 months. This is evolving. I don't want to go into too much details, but there is evolving data that you could do DAPT, advanced antiplatelet therapy, anywhere from 1 to 3 months, followed by ticagrelor monotherapy with no increase in ischemic events and some reduction in bleeding events. Let's go to next patient, 73-year-old with history of hypertension, dyslipidemia, presence with chest pain that started 4 hours ago. She appears with severe distress, blood pressure is low, 86/43. She is tachycardic, physical exam reveals crack of her scapula, so she is in pulmonary edema, JVP is elevated. 12-read ECG shows sinus tachycardia and 3 mm ST depression in intralateral leads. Her initial troponin is 23, which is already high, and next troponin is 73. Creatinine is mildly elevated at 1.5. And what would you do? Should you undergo pause? Should you take her to the cath lab and do revascularization? Only should you take her to the cath lab, revascularize her, and put in Aquila, which is a microaxial intravascular flow pump. Should you do fibrinolysis? The choices are still here. Or should you do vasopressors to get her blood pressure up and then take her to the cath lab? I'll give you 10 to 15 seconds to respond. Yeah, majority of you chose emergency revascularization and placement of Impella, which is the correct answer. The management of cardiogenic shock has changed quite a bit. It used to be cardiogenic shock in the setting of ACS, either ST elevation or non-ST elevation was associated with 80% mortality. So 4 out of 5 patients with cardiogenic shock died simply because 40 or 45% of the myocardium is typically damaged in cardiogenic shock. The shock trial by Judith Hoffman changed that paradigm and reduced mortality by about 20%, so reduced from 80% to 60%. And these were individuals who typically underwent PCI, rarely cabbage, but revascularization improved outcomes. More recently, one trial, the Rangers shock trial, showed that putting in an Impella in these individuals reduces mortality further to maybe 45%, so another 15% absolute reduction. We still have about 40 to 45% mortality. So these individuals don't do well, but at least gives them a fighting chance, revascularizing them, putting in an Impella. When I was a fellow, we didn't have Impella, so we put balloon pumps in all of these individuals. What we know, balloon pumps don't work, ECMO doesn't work, both are associated with worse outcomes. Impella, now the danger shock trial has its own limitation, including open label to 10 years to recruit the patients and 50 or so patients, but it's the best data that we have. And in patients with ACS and cardiogenic shock, emergency revascularization is certainly recommended. Class 1. This is based on the shock trial, and this has been a recommendation for the last 2 decades. You do not do non-culprit vessel in cardiogenic shock. We talked about that. And in patients with severe or refractory shock with ACS, insert microaxial intravascular flow pump, which is the impeller for all practical purposes based on the danger shock trial. We know that we can use it for at least short term, and again, there has been multiple studies, at least 5 studies with balloon pump, including one presented at ACC 2 months ago, showing no benefit and increased bleeding. Similarly, VA ECMO, which can be very helpful in certain conditions of shock, also in large pulmonary embolism, is not beneficial in cardiogenic shock. Correct answer is revascularization with impeller based on the 2025 guidelines. And take-home message again is that revascularize them as quickly as possible and put in an impeller device. And typically we go to the radial, and if you have 2 operators available, which we have typically during the daytime, during the nighttime, we put in an impeller first and then revascularize, get the heart better flow. And with that, I will stop. Happy to answer any questions you may have or any comments on practice here.
Typical scenario in our country is that most of the peripheral is not quickly reachable vehicle or any transportation system to reach the PCI center. So I am setting one example. Yesterday my patient presented to a non-PCI center, thrombolytes and referred to a PCI center. The patient reached to the PCI center after 24 hours, ongoing chest pain and QA with probably 12 ECG. What should be our treatment modality, either medical management or immediate invasive angiography and subsequent dialysis?
Great question. This is not an unusual scenario in some of our rural hospitals. What we try to do, try to airlift them. So we try to do fibrinolysis is a great strategy if you don't have PCI. Still 60%, if you look at the data, just to 140,000 patient data, at least 60% of the time you're going to get normal flow. But fibrinolysis at the same time is incomplete revascularization. Just dissolving the thrombus, underlying lesion is there. Typically, we tend to do PCI after 3 hours and as early as possible. Sometimes logistically, they may not make 2 hours, like you mentioned, 24 hours. Now, if the patient has completed infarct and no chest pain, we leave them alone based on the whole trial. Ongoing chest pain means there is myocardium that is viable. We would take that patient to the cath lab, revascularize it. And often we'll find suboptimal TVT flow and stenosis, but anybody with ongoing ischemia, it's reasonable to take them to the cath lab. If they have completed the infarct, then they fall into the old trial category, and then there's worse outcomes. If they're fully queued out, the chest pain is dissolved, the myocardium is all but dead. But ongoing ischemia, ongoing chest pain, dynamic ST changes, they need to be taken to the cath lab and revascularized.
So this is giving only the clinical outcome or there is a mortality benefit in this case also?
There is certainly reduction in or improvement in quality of life chest pain. There is some data, observational data, that it leads to improved outcomes, including particularly reinfarction. There hasn't been a randomized trial on this subcategory of patients who get fibrinolysis present late, because the goal is to get them early, within 24 hours. But there is some observational data they do better with revascularization, particularly with respect to chest pain and reinfarction.
Because they have said this question, because in our guidelines, the 24 hours, the time limit for 24 hours for this year. Thank you, sir.
Absolutely. My pleasure.
One more question, sir. So, hello. So, as you said, sir, ticagrelor is been an important antiplatelet that has emerged. But here in Nepal, we have seen every third or fourth patient of ours complaining shortness of breath. And that too, to an extent, that they are worried that they are having a heart attack again. So, a stage comes when we have to switch them to clopidogrel. So how often you face this problem in your population?
I think the FDA data suggests that 10 to 15% may get shortness of breath. It varies from anywhere from mild to severe. Often patients with mild shortness of breath with tricuspid, we watch them, we reassure them, we do repeat troponin, maybe a repeat EKG that this is not heart related. And often it goes away. For the individual who have more severe symptoms or who the symptoms do not go away or becomes nuisance or bothersome, we push them to either prasugrel or clopidogrel in those individuals. But the 10 to 15% includes some people with mild who will go away. But otherwise, if the symptoms persist, the entire goal of doing anything is to make people feel better or make them live longer. If we are going to not make them feel better switch to another drug.
So switching is the only answer, no any other answers?
No, really, people...
One is the counseling. One is the counseling to the patient that it's just a side effect of a drug that you can have immediately. Most of them, they complain after the intake of the drug, after half an hour or an hour, they start complaining of shortness of breath. So my practice, I do counsel them because I think it's important for them to be at least for a month or 2 weeks to be on ticagrelor and aspirin, and then if they are very much non-compliant, then I switch them to clopidogrel. And next question, sorry sir, any comments?
Yeah, no, great answer. I think counseling works, and as you say, you hit on a very important point. The highest risk is early on. So if you can keep them, reassure them, and often I've seen the mild shortness of breath go away once they understand. If you can keep them from 1 to 3 months with a potent antiplatelet therapy, that's, I think, a great suggestion. Go ahead, sir.
And sir, how often you have faced 2 culprit vessels at the same time, like LAG and SIR, and what will be your strategy?
And the culprit vessel, the whole concept of culprit vessel is subjective. There's data that include intravascular imaging. There is often multiple plaque rupture. There's high rate inflammation. We tend to pick the artery with the least flow or the subabdominal flow that looks hazy. If you have 2 culprit lesions, anyway, you are going to do complete revascularization. But if it's 2 culprit lesions, you're worried, it looks like hazy, it's thrombotic, both vessels have suboptimal flow. I would go ahead and fix both lesions in the index procedure rather than staging it.
And sometimes when we are exhausted with opening one of the culprit vessels and we are overburdened with the contrast board and also, then in that context, do you have any other suggestion?
That happens with us too. That the first lesion was harder for whatever reason, and we have used up a lot of contrast. There's a lot of worry about radiation too. We monitor that very closely. We use less and less of GP2B3A, but if you think there's 2 culprit lesions and one of the ones we couldn't approach because of this limitation, I'd keep the patient. Typically, we use a lot of eptifibatide. We don't use abciximab, and tirofiban is not that much available in the US. So I'd keep him on a GP2B3A. I think in India, tirofiban is still available. I would assume it may also be available, but I'd use a GP2B3A till I fix in addition to dual antiplatelet therapy, till I fix the next culprit or the other culprit lesion.
Thank you, sir. And in that case, sometimes I use intracoronary lytic as well.
You could, one of the concerns, intracoronary lytics we used to use, Cindy Grimes made it popular in the setting of no reflow particularly or large thrombus. We use very little of it now. I think the concept is that in the coronaries, or at least arterial thrombus is platelet rich. GP2B3 works better. Venous thrombus is fibrin rich, fibrinolytics work well. But if it works, you don't argue with success. But we use very little intracoronary thrombolytics or fibrinolytics now.
Thank you, sir.
Very welcome. Great question.
Actually, I had a small question. It was regarding the GP2B3 inhibitor as well. Intracoronary, tirofiban or FG5 as such. How often do you use in such cases, as you mentioned in case number 1, And also in ad hoc PCI, which were not receiving antibiotics initially. In such cases also, we feel comfortable enough to give a small amount of coronary, intracoronary before standing. So what's the practice and what's the guideline? Thank you.
GP2B3 in the 2007 guideline was class 1. Became class 2A in 2014, now it's class 2B. We use very little GP2B3A these days with the availability of ticagrelor and prasugrel. If there is suboptimal flow, we use it intravenously, again mostly eptifibatide. We almost never use intracoronary. If you look at the intracoronary data, there's probably the most data with intracoronary is with abciximab, but that is not available right now. The pricing was such differential, at least in the US, close to $3,000 versus $150 for tirofiban and eptifibatide. We'll occasionally use it, if nothing is helping with the no reflow. Otherwise, what we'll do, eptifibatide in bolus, the dual bolus in the Esprit trial from Duke University works so fast. We don't do intracoronary, but we will do the double bolus and then do the PCI.
Thank you. Thank you, Dr. We won't be taking many more questions. Thank you, Dr. Mukherjee, for your insightful and interactive talk. We'll stick to one or two questions because they have flight to catch. So, for next, many clinical trials in hypertension have examined whether treating to specific diastolic or systolic blood pressure pole will reduce cardiovascular outcomes or mortality compared with the higher blood pressure pole or normal. So Dr. Kushman in his next presentation will review whether it is important to treat to specific pole. So let's welcome Dr. William Kushman to deliver his presentation on the topic under pressure, the evidence-based quest for optimal blood pressure targets in hypertension. Dr. William Kushman.
Thank the ACC and the Cardiac Society involved and Sun Pharma for putting this together and for asking me to come speak. Try to figure out the technology here. So what I want to do is to talk about the blood pressure goals. What should we treat the patients to in terms of their diastolic and systolic blood pressure? Certainly hypertension is very common. And I think you probably have at least 25% of your population with hypertension, and I think that's based on 140/90. If you were to use the levels that are now often used in the United States, then it would be a lot higher than that. And about 50% of American adults have hypertension. And throughout the world, and I assume here, we don't control many of our patients to the blood pressure levels that are recommended, even in somewhat older guidelines. So what I want to do is it's extremely helpful to identify patients with hypertension and get them on treatment when it's indicated. But in addition to that, we can get further benefit by going to the goals that have been shown to be beneficial in clinical trials. Here are my disclosures. So let's start with a case. This is a 52-year-old man who comes to your clinic for evaluation of his blood pressure. This is the second visit with you, and his blood pressure at the previous visit was 152/94, and so today his blood pressure is very similar, 154/92. He has no history of headaches, dizziness, syncope, chest pain, dyspnea, palpitations, or edema, and he has no other major diseases. May not sound like a lot of our patients, but he has a family history of hypertension and diabetes. His physical exam is unremarkable. He's not overweight. He exercises regularly, and EKG and initial lab are unremarkable. You decide to initiate antihypertensive medications because of the last visit. You advised him on various lifestyle interventions that he can undertake to help lower his blood pressure, and he's begun that. So, what I want to initially ask here is not so much what the guidelines recommend, but in your practice, what would you treat this patient to eventually in terms of his systolic blood pressure goal, either less than 150, less than 140, less than 130, or less than 120. I guess we can close that. I guess I can't do that. Here we go. Okay. So most of you would treat to less than 130 systolic. And so I'm not going to give a right or wrong answer because I just wanted to know, and for you to know amongst each other, what you generally would do. So, secondly, with the same case, what would you treat the diastolic blood pressure to? What goal would you choose? Less than 90, less than 85, less than 80, or some other goal or no goal whatsoever for diastolic? So we can go back to the QR code. So it's already showing you the results. Okay, so most of you would treat to less than 80, some to less than 85, a few to less than 90, and none other. So what I want to do then is to start with the diastolic hypertension trials. Can we close the here we go. Okay. So, and I'm going to do this fairly briefly. These were studies that were started in the 1960s. So, prior to the 1960s, virtually no one was treating hypertension, and even in the 1960s, unless it was very severe. So, malignant hypertension, extreme elevations, maybe with end-stage renal disease, people were treating. But in the 1960s, there first became available drugs that we could use chronically on an outpatient basis that were actually well tolerated. And the thiazide diuretics were the mainstay of that initial therapy. And then there were several others, including reserpine and hydralazine, all of which were better tolerated than what was available up until that point. And so Dr. Ed Fries from the Washington, D.C. VA and the Veterans Affairs System, a cardiologist, put together a bunch of cardiologists and did the VA Veterans Administration Cooperative Study. And let's see, do I have a pointer here? I don't know if, yeah, it doesn't show up on that screen. Okay. So the first study was the VA cooperative study. And that took people who had diastolic blood pressures above 90 to 129 actually, because firstly no one in that range without severe complications was being treated, and randomized them to treatment with a thiazide type diuretic, actually hydrochlorothiazide 100 milligrams a day, and reserpine and hydralazine. And the other group was not treated. And they treated the treatment group to a goal of less than 90. And I'm not going to show the results, but they showed a very dramatic reduction initially to those in the more severe range, 115 to 129. And that stopped that part of the study, which was going to be a 4 or 5 year study, stopped that part of the study after about 18 months. And then the second part, the 90 to 114, was stopped after just 18 months, just a year and a half. And I'm sorry, 3 years. 3 years. And so the problem with the VA study, it wasn't very large. It was only men, and there weren't a lot of patients in that 90 to 114 group. And even Dr. Fries was concerned that this was a pretty small group to recommend treating millions and millions of people in this, what they then considered this milder degree of hypertension. So the National Lung and Blood Institute initiated the hypertension detection and follow-up program. And the other issue about the VA study was cardiovascular events, which we now often use for our endpoints, but it was not mortality. And so at that time it was thought that, well, you really need a hypertension study to show mortality benefit. And so HDFP took men and women above 90 diastolic and randomized them to treatment in a special treatment clinic with step care therapy. And then the other half of the patients were randomized to just usual care, which for the most part was no care. Although because of the VA study, people in the higher blood pressure range were often beginning to be treated. And so, again, the goal was about 90 millimeters of mercury, and they showed a very impressive reduction in total mortality as well as cardiovascular events, and for all subgroups, blacks, non-blacks, men, women, somewhat older and younger, even though it wasn't a very old population. And then two other studies done in Australia and in Europe did similar kinds of trials, also confirmed that treating to 90, or in the last one, 95, did benefit cardiovascular events when you treated to that same level. So after that, there was some concern that if you treated the diastolic too low, you may actually do harm. And that was the so-called J curve. And that was based on some observational data from these trials, that the people with the lowest diastolics on treatment may have done worse. And so there was a study looking, and many people believe that if you treat to a lower level, you would get benefit. And so the HOT study, the hypertension optimal treatment trial, was initiated with goals of 90, 85, or 80. And what they found was that there was neither harm nor benefit in cardiovascular outcomes to any of those three goals. So getting to 90 or below is beneficial, but 95 or 90 is again, was neither harmful nor beneficial. Now, then the focus switched in the 1980s to, even though HOT was done in the 1990s, but we began to be concerned more and more about systolic blood pressure. And so the systolic hypertension, the elderly program, the first of these trials, was initiated by the National Heart Blood Institute of the NIH, and taking people above age 60. And all of these systolic blood pressure trials started at age 60 or higher, and they treated to a goal of essentially 150. It was less than 160, at least 20 millimeters of mercury, and that averaged out to 148. And then, and so that study, as you see, showed a very nice reduction in the primary outcome of stroke, but also overall cardiovascular events. And heart failure was impressively reduced by about 50%. So then the Europeans thought that, well, we need to repeat this study, and we'll do it in Europe. And so they did a very similar study looking at stroke as the primary outcome in people over age 60 with isolated systolic hypertension, treating to less than 150 exactly. And they showed also a very nice benefit in terms of cardiovascular outcomes. And then there was concern about people over age 80 who were not represented very much in these trials because the epidemiology suggested that if you treated hypertension in people over age 80, you may actually increase mortality. And so it turned out that that was wrong. The HIVET study, hypertension in the very elderly, with people over age 80, randomized again to less than 160 versus placebo actually, and showed a very nice reduction in mortality and cardiovascular events. So mortality was the primary endpoint. And so these studies conclusively showed that getting down to less than 150 was beneficial. And then subsequent to that, there were only a couple studies done to look at 140, even though guidelines had often been recommending 140 for many years with no trials showing specific benefit for 140. So these two trials in Japan, the JADOS and VALISH studies, took older patients once again and randomized them to a goal of less than 140 versus something higher, usually above 160. And they showed no benefits on the goal of 140. However, there were very few events in those two studies, so it just wasn't definitive. And so you couldn't say it was either beneficial or harmful. It was just inconclusive. So then, starting in the 2000s, the National London Blood Institute again initiated a study, and this time looking at a much more intensive blood pressure goal. And also, in the context of the trial, looked at intensive or standard glycemia control. The intensive control was a hemoglobin A1C less than 6, and standard was 7 to 8. And that was in over 10,000 of the individuals. And then everybody in that trial, all of them were in the glycemia trial, but then part of them were in the lipid trial, part of them were in the blood pressure trial. And I'm only going to focus on the blood pressure trial. And here we compared a systolic blood pressure goal of less than 120 to a goal of less than 140. And I actually was privileged to be the lead investigator in the blood pressure part of this study. And so we looked at 4,700 patients plus and treated to that intensive goal of 120 versus 140. And we saw an 18% reduction in the primary outcome, the cardiovascular events, but it wasn't statistically significant. And we did see a significant reduction in stroke, but that was only one of several outcomes. And so we reported it as a study not showing benefit for the lower systolic blood pressure goal. Well, after the SPRINT trial came out several years later, we looked back at this data and actually had done this in the initial publication, but didn't try to make a lot of it. But what you see here is that in the first row, you see what we eventually, I'll show you in a minute, saw in the SPRINT study, about a 25% reduction in cardiovascular events. It was significant for the 120 goal. And then in ACCORD, the overall result, as you see down at the combined glycemic arms, was 11%, a little bit different from that 12%, basically the same, but not significant. But then if you look at the intensive, the standard glycemia goal groups, the intensive glycemia group had higher mortality because of the intensive glycemia intervention, and that group did not see a benefit for the blood pressure reduction. But for those from the standard glycemia arm, they showed an identical benefit that we eventually saw in SPRINT, almost a 25% reduction in cardiovascular events. And so that in part is why ever since 2015, when SPRINT was reported, virtually all guidelines have recommended treating people with diabetes and hypertension to the same lower blood pressure goals, whatever that guideline was recommended. And there were meta-analyses that suggested benefit as well. So now to go back to SPRINT. So after ACCORD, or at the end of ACCORD, we were designing SPRINT and initiated SPRINT. We learned a lot from ACCORD about what to do and the fact that we needed a bigger sample size. So here we put over 9,000 people with hypertension into a trial, again comparing the less than 120 systolic to less than 140 systolic. And the primary outcome was a composite cardiovascular outcome, a MACE outcome, and I won't go into the details of it. And each of these trials, especially since ACCORD, have had fairly similar combined cardiovascular outcomes, slight differences. For example, ACCORD did not include heart failure, whereas most after that did include heart failure. And it was going to be a 5-year study, but as I showed here, it was stopped early after 3.3 years. The entry criteria, very briefly, these were people over age 50, not because we didn't think that treating to a lower goal in younger people would not be beneficial, but the fact that we needed older people in order to have enough events to make it a reasonably sized study that we could do in a reasonable period of 5 years. The systolic blood pressure was 130 to 180, on meds or not, and the number of meds, they could be on as much as 4 medications, as long as the blood pressure wasn't in the higher range here. And they additionally had to have additional cardiovascular disease risk, again, to have a feasibly sized study, not that we only wanted the results to apply to higher risk people. And it essentially was the equivalent of a Framingham risk score of 15% or greater, which you could get with older age with chronic kidney disease and non-cardiovascular disease. And that's a higher number than if you calculated the ASCVD risk score for the same population, which probably would have been closer to 10%. But we were at that time using the Framingham risk score. We excluded people with stroke, diabetes, or polycystic kidney disease, not because we didn't think they would benefit, but because there were other NIH studies, like the ACCORD study in people with diabetes, that were already testing lower blood pressure goals in those populations. And then there were other exclusions, severe CKD, even though we tried to over-recruit people between 20 and 60 GFR in the CKD group, and people over age 75 we tried to over-recruit for. We did exclude people who already had a diagnosis of dementia or in a nursing home because we wanted to also look at cognitive outcomes and hypertension as an outcome in sprint. And so we stopped the study early because of an overwhelming benefit that was seen not only for the primary cardiovascular outcome, but for mortality, and published it in 2015. I'll show you some results from the 2021 update because it takes several years to get all the data in and mortality data in, at least in the United States, from our national death index. And so we were able to accumulate more events, not after the study was stopped, but that occurred before August of 2015. And so that's some of the results that I'll show you. The results are very, very similar between the two. So it didn't change the answer when we had more outcomes available to us. So we got a very nice separation in blood pressure, close to 120 for the intensive group, 135 for the standard group. So a nice separation in blood pressures. Oh, and I did want to point out here at the bottom that the number of antihypertensive drugs in ACCORD, it was over 3 drugs for the intensive group to get down around 120. But for the in sprint, partly because we were using a little bit more effective drugs, we had an average of about 2.8 drugs in the intensive group, 1.8 in the standard group, so about 1 drug difference. However, we were on average using higher doses in the intensive group as well. And so, as I've alluded to already, we saw very nice, in this case, a 27% reduction in cardiovascular events and mortality, as I'll show you in a minute. And that was the primary reason the study was stopped. But the total mortality benefit at the bottom here, the 25% reduction, also by itself would have caused the Data Safety Monitoring Board to stop the trial. There were some who criticized and said, well, it's only because you reduced heart failure. And that's why you saw this benefit. You were using a good diuretic, chlorothalidone, and so even without heart failure in the outcome, we saw a benefit. And then we saw a benefit for most other of the cardiovascular events, including a 37% reduction in heart failure that I alluded to already, but cardiovascular death was significantly reduced as well. The stroke was not significantly reduced. It went in the right direction. But I didn't point it out on the previous report slide, but we didn't see a benefit for the intensive treatment on stroke in ACCORD until after 3 years. And we stopped sprint just after 3 years. So I think that's probably the reason we didn't see a benefit in stroke. It would just take longer to show benefit. But other trials have conclusively shown that we do see a benefit on stroke as well. And when we looked at all of the subgroups that we had identified previously, we saw benefits, no heterogeneity. So all the subgroups seemed to be benefited similarly, whether they were older, above 75, or younger, men or women, chronic kidney disease, and so forth. So, well, as I mentioned, we excluded people with diabetes or prior stroke, so we really couldn't say much about them. But then when subsequent analyses were done, both by the sprint investigators and others outside of sprint, virtually every subgroup that was looked at later, such as prediabetes or not, was benefited as well. So there was no heterogeneity, as I mentioned, in the treatment effect by pre-specified subgroups. So adverse events, certainly we and others were very concerned when you treat people less than 120, are you going to get more adverse events? And what we saw was that overall serious adverse events that were reported were actually no different between the two groups. It's not what we expected, but it was very encouraging that we didn't see a significant increase in adverse events overall. We did see specific 90 or so that patients can get symptomatic from hypotension. But in this case, we saw that measured orthostatic hypotension in the intensive group was less common than in the standard group. That now has been replicated in other studies, and some of us put together a meta-analysis fairly recently showing that overall, more intensive treatment reduces orthostatic hypotension rather than increasing it. Now, there are probably exceptions to that, because we excluded people who had significant orthostatic hypotension before coming into the study. If their systolic was above 130 and their systolic went to less than 110 standing, when we screened them, we did exclude them. So people with autonomic neuropathy, causing orthostasis, those kind of things were excluded from the study. And certainly they're a difficult population to treat if they also have hypertension. What we did see is some acute kidney injury, some of what was called hypotension, and electrolyte disturbances that were significantly but a little bit more common in the intensive group, and really less than 1 or 2% more in the intensive group. And by and large, those outcomes, those adverse events, were very manageable. And so there's a whole paper on the acute kidney injury development, and these patients recovered very quickly. We might adjust the medication some, but we actually often still went back to the less than 120 goal in those patients, and it did not predict long-term adverse outcomes on kidney function. And certainly, because we used more diuretics in the intensive group, then there was a little bit more hypokalemia and hyponatremia, but not a lot. As I say, it was only 1 or 2% more. And there was no increase in falls and fractures, and older patients in the study, above age 75, had more serious adverse events numerically, but no difference between the intensive and the standard group. As a matter of fact, a lot of these other outcomes weren't significantly different in the older patients. So then about 6 years went by before the next systolic blood pressure trial was reported. And this is from the STEP study. These next 4 studies I'm going to mention are from China. And I'll do it fairly quickly. But this is a fairly large study, 8,500 Chinese patients, 60 to 80 years of age, randomized to 130 versus less than 150, and had a fairly similar composite cardiovascular or MACE outcome. Got a fairly nice difference. The blood pressure obviously was not as low because the goals weren't as low in this study, but 130, and saw a 26% reduction in cardiovascular rates, almost identical to what we saw in spring. And then a couple years later, in 2023, the China Rural Hypertension Control Project was published. And this was a study where a large number of rural Chinese villages were randomized by village, and the people with hypertension in them, to either a goal of less than 130 over 80, which the 2017 ACC AHA guidelines have already been recommended, to usual care. And those in the treatment group got these non-physician community health care providers and free medications. Those providers, which in China used to be called barefoot doctors. And then the other group didn't get free medicines or a specific provider to them. So fair or not, that's what they found in almost 34,000 people with a very large blood pressure difference, 23 over 10, and saw very substantial reductions in cardiovascular disease, stroke, and death. So again, that's with a systolic goal of less than 130. And then last year, the next study done out of China, the ESPRIT study, was virtually identical to SPRINT. It was designed and conducted very similar to SPRINT, and it showed 120 versus 140, very nice separation in blood pressures, and again, a significant, not quite as robust, but a significant reduction in cardiovascular events. And importantly, they did include people with prior diabetes and prior stroke, and they showed no heterogeneity in those subgroups. So it looked like both of those were benefited, even though the confidence intervals crossed one at times. So then Paul Welton and his colleagues at Tulane in New Orleans, Louisiana, put together a meta-analysis of the studies so far that have been done with either a 130 or 120 goal. And so the top group here is both the 130 and the 120 goal, basically less than 130, showed substantial benefits, 22% reduction in cardiovascular events, and then the bottom group are the 120 goal studies, the subgroup among them, that also showed a very nice 18% reduction in cardiovascular events. So whether you're looking at 130 or 120, these showed benefit. Well, so then, about the time they published that meta-analysis, the results of the BP Road study came out. And this was done exclusively in diabetes, very similar to the ACCORD trial, comparing 120 to 140 systolic, and showed they got a very good difference in blood pressures, and again, showed a significant benefit on cardiovascular events. And looking at every subgroup, they also showed no heterogeneity and showed a benefit for this more intensive blood pressure goal. So we have this same patient, and the question I want to ask now is not what your goal would be, but what would the 2017 ACC-AH guideline be? Would it be less than 140 over 90? Is that what they recommend, or less than 130 over 90, less than 130 over 80, or less than 120 over 80? So you can vote. Let's give it a few seconds before we go to the answers. Okay. Can we look at the answers? All right, so, so most of you got it right. 130 over 80 is what they recommend. And people are changing their votes. Some do 140 over 90. So it turns out that guidelines around the world have either recommended the 130 over 80, some have recommended 130 over 90, and some have recommended 120, whether they have a diastolic goal or not. For example, the International Kidney Guidelines recommended less than 120. So let's go to the next slide. So the guidelines, ACC-AHA guidelines, as most of you voted, do recommend 130 over 80. The important thing to notice on this slide is for diastolic blood pressure, the level of evidence is not there. It's basically expert opinion. There are no trials, as I showed you earlier, that have proven that less than 80 is beneficial. They do recommend if you're going to treat somebody, then 130 over 80 is what they recommend for the goal. But I think as we approach our patients, I think the 130, we now have very good evidence that is, if you will, a minimum goal that we should shoot for, and a lot of evidence now that even 120 is better. We were hoping the ACC-AHA guidelines, I wasn't involved in them, we were hoping the updated 2025 ones would be published and presented at the ACC meeting recently, and unfortunately they weren't. So they are going to be published later this year. And I'm not sure exactly when, some have said June, or it may be fall at the American Heart Association meeting. But so we'll have to see what they say. But I think in terms of practice, I think it's important for us to realize that the 80 is expert opinion. I don't think it's harmful to go to 80, but we have very solid evidence for 90 diastolic, and we need to keep that in mind when we're treating our patients, I believe. And then we have very good evidence for either 120 or 130. So I think I'm going to stop there. This is my summary slide, and I'll leave it up there for a minute, and you also will have access to the slides, but it basically summarizes what I've said in terms of the evidence. I'll be glad to answer any questions now. We've got some time. And a little bit later this afternoon, I'll talk more about how to.
Williamson. So we are just in the guideline, if you go in the summary, in the beginning, they are taking about the complete risk stratification during this hypertensive person. They are not only talking about the hypertension only. So when you are calculating this CV outcome, whether we are going to consider all the risk factors in the hypertensive person or not.
I couldn't hear everything you said. You're saying, should we consider risk factors?
Yes.
Yes. So the way the guideline puts it together is that to initiate treatment, then for the 130 to 140 group in particular, to look at cardiovascular risk. And then I'm not covering that today, but basically in that include low-risk people. So if their risk is high, they already have known cardiovascular disease or end-organ damage, then they do recommend initiating therapy in that group, and also for the 80 to 90. But if they are at low risk, then to initiate drug therapy at 140 systolic or 90 diastolic. So I think that's reasonable. Then what I pointed out is that if you do start therapy, then even for the low-risk individuals, they're recommending 130 over 80 is the goal. So the same goal for everybody once you start therapy.
So even in the very high risk group and the low risk group, we have the same target level of blood.
Sorry,
In very high risk group.
the speakers aren't coming up.
What he's saying, irrespective of risk, the goal should be 130 even at high risk.
Yeah, and that's what the recommendations are. We have to admit that we did include lower risk people in theory in those early diastolic hypertension trials, people down to age 30 without known cardiovascular disease. So clearly the 90 it should be a minimum goal for them, and that may be reasonable. And I actually do that often in clinical practice. Is the diastolic goal, particularly for a lot of young people, where we didn't test the systolic blood pressure goals. But for the systolic, again, the young people weren't included, but usually diastolic elevation is what the problem is in younger people. So for older individuals, the systolic and the diastolic usually is not as important, it's often low. And so there, even for the low-risk patients, I would still probably shoot for at least the 130 goal. But it may be reasonable to separate out. Some guidelines do separate them out, as you say, and have different goals. Okay, thank you.
The next session is from Dr. Devendra Mukherjee again, and on this session he will be focusing on the need for evidence-based approach to chest pain evaluation and its management. Let's all welcome Dr. Mukherjee to deliver a talk on contemporary approach to patients with chest pain.
Thank you again, Dr. Prajapati, and good afternoon again. We'll try to again keep this interactive, keep all of us awake, including myself. We talked about acute coronary syndrome, which is of course a subset of individuals with chest pain, and right now we'll look at a broader group of patients who present with chest pain. Chest pain is one of the most common what we call DRG or diagnosis-related group of patients presenting both to the emergency department as well as to physician offices, PCPs, and cardiologists. So this will focus on approach to chest pain based on a guideline that was published a few years ago. Again, I do not have any conflict of interest. I was in the leadership of this guideline with Martha and Phil. And specifically, we'll look at diagnostic approach in this patient. I already talked about chest pain and acute coronary syndrome. This is a common problem. Acute coronary syndrome, chest pain is a common problem in Nepal. There's a lot of ST elevation myocardial infarction. There's a lot of chest pain in younger, middle-aged adults compared to older adults in the US and Europe. So certainly something that needs to be taken seriously. Now, when somebody presents with chest pain, the three big cardiovascular conditions we should be thinking about. The commonest one is acute coronary syndrome. There are two other biggies. One is acute aortic dissection. Well, literally minutes can make a difference between life and death, and large pulmonary embolism. We're not going to focus on them, but something to keep in mind. There are some non-cardiac conditions that can present with chest pain too, and those are, one of them is a perforated esophagus or ruptured esophagus, and another is tension pneumothorax. So specifically, we'll talk about diagnostic evaluation of patients, recommended testing strategies, and we'll not only look at acute chest pain, but we'll also look at chronic chest pain or stable angina when they present to the physician's office. Now, with any medical condition, history and physical is key. The character of the chest pain is very helpful in diagnosing whether it is cardiac, non-cardiac, and may help you point in other direction. In general, central pressures, squeezing, gripping, heaviness, tightness, the old Levine sign, standard textbooks of cardiology and medicine used to show a picture of somebody bending over with a fist on their chest. That is typically likely to be angina or acute coronary syndrome, whereas sharp, flitting, shifting, turning position of pain is less likely to be cardiac in origin, more likely to be musculoskeletal. Somewhere in between is stabbing, left-sided dull and aching being more likely. Tearing, ripping, most severe pain ever experienced, think of acute aortic dissection, particularly if they are hypertensive, they have pulse deficit, new aortic triggers murmur. So I mentioned do a history and physical. That will give you a clue as to what the etiology may be. Do a ECG if there is elevation myocardial infarction. Primary PCI, which is available nowhere in at least 2 centers, maybe more in Kathmandu, but primary PCI saves lives. So take them to the cath lab as quickly as possible, preferably within 90 minutes. If you just elevation, manage pericarditis, if they have ECG changes and ST depression, think of non-ST-ACS and treat them appropriately. One of the recommendations is if the suspicion for acute coronary syndrome is high enough, then if the initial ECG is normal, repeat an ECG or do a posterior lead. Finally, if there is an arrhythmia, treat it like AFib or SVT. This is kind of a 10,000-foot view. What used to happen 10, 15 years ago, everybody presenting with chest pain in the emergency department would get stress testing or some kind of testing, exposing them to radiation. Obviously, there is a cost, there's delay, emergency departments getting clogged. The guidelines recommend no testing for asymptomatic individuals. Obviously, they're not having chest pain. But individuals who are deemed to be low risk based on a clinical decision pathway or some risk stratification do not need urgent testing. That doesn't mean they don't need anything done. That just means they don't need urgently something done or tested in the emergency department. They need to follow up with their PCP, they need to follow up with their cardiologist, and they need some testing, but very importantly, if they have ever had a lipid profile, do a lipid profile, check their glycated hemoglobin, control their blood pressure, control their glycated hemoglobin, control their lipids, control their risk factors, which pays huge dividends. The individuals who benefit most from testing are the individuals with intermediate or high risk, and today you have a choice. You can do functional testing, stress nuclear, stress ECG, stress MRI, stress echocardiography, or you can do coronary CTA, which is an anatomical testing, and then you can incorporate functional testing if you have CTFFR available. And then we already looked at acute coronary syndrome patients, and they need to go to the cath lab and get revascularized. We'll start with a patient. This is a young gentleman. He is 33-year-old, presents to the ED for evaluation of chest pain, having chest discomfort after having an argument with his wife. Chest pain is described as substernal, aching, non-radiating, not associated with shortness of breath or backwards. It's pretty severe, 8 out of 10. Started 3 hours ago. He denies any risk factors, denies taking any medication, says he does not have hypertension, dyslipidemia, or diabetes, does not have any significant family history. His physical exam is fairly unremarkable, normal heart rate, normal blood pressure, 12-lead ECG is normal, initial troponin is 1, normal is less than 12 for the Roche assay in our hospital, and the repeat one is 0.9, so basically rules out. So what is the most appropriate therapeutic action? Should you send him for coronary angiography? Should you do coronary CT? Should you discharge home or do a stress nuclear imaging? And we'll put up the QR code for the audience at large. There is no data that low-risk patients urgent testing leads to better outcomes. There's a lot of concern based on data coming out, mostly from Canada and some data out of the US. Every time we do a CT scan, a stress nuclear, or some kind of cardiology test, most of the time we're exposing people to radiation, and we're seeing 20, 30 years down the road increased risk of cancer. So the correct action here is let it go home with appropriate follow-up. It's extremely important. You can follow up with this PCP, you can follow up with the cardiology, but certainly you want to make sure there's therapeutic lifestyle changes, and you use this opportunity to decrease his stress. There is no reason to do any urgent testing at this time, and again, doesn't lead to better outcomes. So important take-home message was that testing not needed for low-risk patients, at least not acutely or urgently. You may do a stress ECG since ECG was normal, or a calcium score 4 to 6 weeks later if he needs additional risk stratification. So here he is, he comes to you, he was referred by his PCP to the cardiologist, and he comes back and is concerned. Why do we have chest pain? And he wants to know about his future risk, and is there any testing that he should undergo? And what would be most appropriate? Should you do coronary angiography, stress CMR, stress nuclear imaging, or a calcium score? And we will put up the QR codes and get your response and input. We can go ahead. I mean, that's great. Majority of you got the correct answer, which should be calcium score. And again, he's low risk to start with. This is a young gentleman going through significant stress because he's had a fight with his wife, and there's no reason to do invasive testing such as coronary angiogram. Again, no data that cardiac MRI or stress nuclear imaging leads to better outcomes. The pretest probability is very low. One of the things we have learned over time is that calcium score is a great prognosticator. 10 years ago, based on just age and sex, you could risk stratify the previous likelihood of chest pain being ischemic or coronary in origin. Right now, by incorporating the coronary calcium score, you can further risk stratify them. And essentially, somebody with a calcium score less than 99 or 0 has excellent prognosis. That doesn't necessarily mean that they don't have plaque, because coronary calcium is looking at calcium in the plaque. But overall, over 5 to 10 years, their prognosis is excellent. And if he's concerned about his risk, that would be a test to do. And certainly, as you look at his lipids, his blood pressure, his diabetes status, there's no reason to do additional testing. Now, there's a different patient, 54-year-old, suboptimally controlled diabetes, hypertension, dyslipidemia, presents to the emergency department with a 10-day of stuttering on and off chest pain, burning in the substernal region, last 15 to 20 minutes associated with exertion related to stress, 12 leading kg issues, non-specific exposure. Initial troponin is 6, so it's less than the upper limit or normal level of troponin. And what would you do at this time? And the guidelines typically just, we look during acute coronary syndrome, looking at Grace, TB. Similarly, the guidelines recommend instead of, most of us try to use a Gestalt or experience, but using a systematic risk stratification score helps stratify them better than just the physician Gestalt. So let's see what the audience response is. We can close. Go ahead. I mean, kind of, this portion is intermediate rest. There's no wrong answer. From the guidelines, they recommend using critical decision pathway, and the reason being that's probably a little bit more objective than our own gestalt or experience and helps risk stratify patients. What has happened in our electronic medical records already incorporates this data and will spit out a score. And we can go back to the slides. So once you do history physical, ECG with an obvious non-cardiac cause, if there's GERD or esophageal or something else, there is no cardiac testing required. If it's non-ischemic like aortic stenosis, ophthalmology, again no non-ischemic testing required. But if you think it's possible ACS, the best way to risk stratify is use a clinical decision pathway to low risk, intermediate risk, and high risk, and we'll look at what that means. The clinical decision pathway that's used most in US and Europe is the heart score or heart pathway. There are others like EDAX and app, name and app. And a heart score less than 3 is low risk, moderate risk is 4 to 6, and high risk is 7 to 10. In our country, the other thing is there is reimbursement is tied to appropriateness of testing, and we have to document that the heart risk score is at least moderate to justify doing testing in this individual. So clinical decision pathway is the recommended strategy, even though you know just based on a risk factor, chest pain for 10 days that she's not low risk. She now gets a second troponin, it's still not elevating, it's in the upper limit of normal. So she's not an acute MI. What would you do? Discharge her because her pain has resolved. You can do a stress nuclear imaging, stress ECG, or do a coronary angiogram. And if we could have the QR code again, please. Thank you so much. The stress ECG, remember her baseline ECG was abnormal. If you do a stress ECG, you're very likely to get false positive. So contraindication to doing just stress ECG is for ischemia at least, is if the baseline ECG is abnormal with non-specific ST changes. And again, she's ruled out invasive coronary angiography may be too aggressive in her. So correct answer, we calculated her heart risk score, came out to be 5, which is moderate risk. So based on that, she'd be eligible for some kind of stress testing. This is a busy slide. I'll simplify it for you. Acute chest pain with intermediate risk, no known CAD like our patient. If they had prior testing, if their recent testing within the last few months, they can be sent home. If it was negative, if it was inconclusive, say you did a CTA which was inconclusive because of calcium or whatever, you can do functional testing versus if the functional testing was inconclusive, you can do CTA. If they have prior severe coronary artery disease that was known but somehow fell through the cracks due to revascularization, send them for an angiogram. Our patient had no prior testing. Here you have UP pause. You can do stress testing including exercise ECG, stress CMR, stress echo, stress PET, or anatomical testing. Because the baseline ECG was abnormal, stress ECG would not be indicated. And again, if she has no ischemia, let her go home, moderate to severe ischemia, then you have to go to the cath lab and get angiogram to determine suitability for revascularization. So she's intermediate risk. Again, we will do stress ECG because baseline ECG is abnormal. But you could do CTA, you could do stress MRI, stress echo, stress nuclear. I always recommend do what is best available. Different centers in the US have do certain testing better based on personnel, based on expertise, based on equipment. So do the testing that's best done. Patients with acute or stable chest pain who are at intermediate risk are the ones that benefit more most from cardiac imaging or anatomical testing. I'm going to spend just a couple minutes on stable chest pain because that is something very commonly present in the PCP. And again, this is a busy slide, very similar algorithm to what we talked about for acute chest pain. You have equipoise between doing anatomical testing with CTA. That's something done well in your hospital. We in the US are doing a lot of more CTAs now, though we still do a lot of nuclear testing. You can do stress CMR, stress PET, stress echo. And again, no ischemia or very little ischemia. They can be treated medically, moderate to severe ischemia, they get angiogram. If you do CT and if you have that intermediate stenosis 40 to 80%, there is CT-FFR to determine significance. There's only one company, another company is now willing to provide that in the US. But you have to ship out the CD of the CTA. All you could do is functional testing to determine significance. And if you think it's significant, again, they go to the cath lab, as you can see, invasive coronary angiography. One other issue that comes up is the individual who keep presenting with chest pain, and if they have risk factors, do you keep testing them? Or is there anything like warranty? Like if somebody has a testing done and it was normal, can you then reassure them and let them go home? And this is the individual, a 54-year-old, who actually ended up having GERD, or esophageal reflux, and myocardial perfusion was normal. And she comes back 2 years later with chest pain. So should you, because she had a stress test 2 years ago that was normal, should you discharge her home? Should you repeat stress nuclear or stress ECG, or just take her to the cath lab? If I could get the audience response, please. We can go ahead and start it. In many of you chose invasive coronary, or half of you chose, and the correct answer is repeat stress nuclear imaging, and we'll look at, you don't want to send her home, she has risk factors. She did have a normal myocardial perfusion 2 years ago, and she hasn't ruled in for an MI, invasive coronary angiogram may be a little bit too aggressive in her, and if we can go back to the slide. This was a myocardial perfusion completely normal with no reversible deficit. Now the warranty is based on limited data. The most robust data is on CT. If somebody has a normal CT angiogram, even though the warranty here is 2 years based on the guideline, even after 5 years, the risk of a cardiovascular rhythm is literally close to zero with a normal CT. Normal coronary angiogram, similarly, there is data that's older, but at least 2 years the event risk is low. Normal stress testing, what you're looking at hemodynamic significance in the flag, and typically it's about a year based on limited data. I want to explain that this is for stable or chronic coronary artery disease. This warranty is not for AMI. Somebody comes in even 6 months ago had a normal stress test, or 3 months ago had a normal stress test, comes in with an AMI, they need to go to the cath lab. The plaques that rupture are often the 30-40% non-hemodynamically significant lesion, and this warranty is only for stable chest pain ruled out. So the correct answer is B, a repeat nuclear imaging. You can do anything, a repeat or a CTA or a stress CMR, but some kind of assessment is with 2 years is reasonable. Before I open up the questions, this is my final presentation for the entire session. I do want to give a huge thanks and a big shout out to Ms. Joel Lee from ACC for arranging this program, for taking great care of us and keeping us in line. Please join me in giving her a big hand, and I will I'm happy to answer any questions. Give people a minute. If no questions.
for your insights. Now we welcome questions from the audience. Since there are no questions, we'll move on to next presentation. Have you ever wondered whether it truly matters which class of hypertensive medication is used first, or how different your drug classes should be combined or added over time? What are the guiding principles for effective blood pressure management? In our next session, Dr. William Cushman will be addressing these important questions and providing clarity on the optimal strategy for selecting and combining anti-hypertensive medications. Dr. William Cushman.
Thank you. So, now what I want to do is to talk about how to put the medications together. You all do this a lot, and it may not be something you're not aware of. In the United States, we do see a lot of what we call clinical inertia, where people are really uncertain how to add drugs, how to combine them, increase doses. One of the things we were supposed to do is bring to you messages from what was presented in the American College of Cardiology meeting. And it turned out I said that the guidelines, sadly, were not presented there, so we couldn't bring that to you. That would have been a lot of fun to look at and discuss. The only late-breaking session or late-breaking presentation that had to do with hypertension was an aldosterone synthase inhibitor, lorundrostat, I believe is its name, that was used in resistant hypertension. It was effective versus placebo, and that's not really astounding news. We don't know how it compares to spironolactone, for example. And so you can keep your eyes out. There are several of these aldosterone synthase inhibitors that shouldn't have the side effects of spironolactone, for example. We're not sure how they compare in terms of efficacy, and they're not approved yet on the market. Initially, at least in the United States, they'll be very expensive unless Trump prevents that. But here are my disclosures again. The other thing that, before we get into the case, there were several smaller sessions that in hypertension that one of the most repetitive things that were presented had to do with one way or another with our not controlling blood pressure very well in patients with hypertension, and a lot of it attributable to what we would call clinical inertia. So what I want to discuss today is what the guidelines recommend, but also just our experience, particularly from some of these trials in treating to these more intensive blood pressure levels, just practical aspects of putting the medications together. So here's the first case. A 63-year-old woman comes to your clinic in follow-up for management of her hypertension. She's currently taking lisinopril 40 milligrams and amlodipine 10 milligrams for her hypertension. She's got no bothersome symptoms except chronic, dry, non-productive cough. She's continuing to try to make lifestyle changes. Her blood pressure today is 148/96, so not at the goals that we discussed earlier. And the rest of her physical exam is normal, except for an S4 and 1+ pitting pretubular edema. Her ECG shows LDH, and her recent routine lab tests are normal. So, what would be the most appropriate next step for this patient? Add clonidine, 0.1 milligrams twice daily. Add metoprolol succinate, which is a long-acting metoprolol, 25 milligrams each morning. Change lisinopril to 20 milligrams to telmisartan, 20 milligrams each morning, and add chlorothalidone, 12.5 milligrams each morning. Or keep her medications the same, but bring her back for another visit and confirm that her blood pressure is still elevated. So here's the QR code. So most of you, looks like you've already voted. And I'm not going to go into most of you voted what I would do, but we'll go into that more later. So when we're treating hypertension, and we decided to use drugs, it's still appropriate to use lifestyle therapy. Now, there are a lot of people who don't yet have hypertension, that have blood pressure getting close to the hypertensive level. or family history of hypertension, and it's appropriate to recommend lifestyle. And so all the guidelines do that, including the 2017 ACC/AHA hypertension guidelines, is to, even when we start medications, to still emphasize the lifestyle aspects. And I'm not going to go into a lot of detail here. Certainly some of these are easier to do than others. Some are more effective than others. All of these that I'm going to show on these two slides, not just this slide, have the most consistent data and the most effect in terms of blood pressure reduction. Weight loss has certainly been historically one of the most difficult things for us to achieve, either individually or certainly for our patients. Now with the GLP-1 agonists available and other weight loss drugs, we'll see more patients, and I'm seeing a lot of them already in my practice, where patients are coming in having lost weight and lowering their blood pressure and needing less medication, for example. Healthy diet, and so by and large, the DASH diet seems to be the most effective combination of putting foods together. And certainly, that's not the only thing, but what Nash Harlan and Buddy Institute did is they tested various aspects of dietary changes. And what they ended up with is what's called DASH, or the Dietary Approach to Stop Hypertension. This is essentially 8 to 10 servings of fruits and vegetables, low-fat dairy products, and low-fat small portions of meat. And you can do the same thing modifying either a Mediterranean diet, which is often even better for lipids, or even a vegetarian diet. And so there's certainly ways to alter diet to make it more effective in lowering blood pressure. The next is lowering sodium or salt intake. The guideline recommends less than 1,500 milligrams of sodium a day because that was the most effective in clinical trials. But if you're aware of how restrictive that is, it's very hard to achieve in our patients. But certainly anything toward that is effective. And some guidelines recommend 2,300, which is a more traditional no salt added diet, or 2,000. And again, that's very hard to do at least in societies where we have a lot of packaged and prepared foods or eat out a lot. Because at least in most settings like that, in the United States, 70 to 80% of the salt we get is in that, not what we're adding. Certainly if people are cooking their foods at home predominantly, and encouraging them not to cook with salt or sodium types of additives, and even if they just add a little salt at the table, that's better than cooking and saturating the food with salt. And again, that's one of the more difficult things I can do. Enhanced intake of dietary potassium, to me, is just redundant to the DASH diet, because that's the best way to do that. Regular physical activity, and you can look at the details of this, can be effective at reducing blood pressure, and then moderation of alcohol intake. And I actually think for many of our patients who are drinking excessively, moderation of alcohol intake is probably the easiest thing, or at least one of the easiest things to do of all of these, because a lot of people that are drinking 4, 6, 8 drinks a day on average don't realize it's harmful because they seem to be tolerating it fine, and yet it's having adverse effects on their health, including elevating their blood pressure. So those are all things we can do. Now, the one other thing I wanted to mention that I won't take time to go into here is that all the guidelines are, when they recommend treatment goals, for example, and what you do in terms of management, are based on taking blood pressures in a very systematic way and taking them correctly, in essence. And it's not that hard to do. It's psychologically hard to allow the patient to sit and rest without being spoken to or talking, and using the right cuff size and what have you. So I would encourage you to look at what the various guidelines and papers recommend about blood pressure management. And many experts and many committees are moving toward recommending that in the clinic setting that we use fully automated blood pressure machines where you can set it up, have the patient in a quiet setting. They don't have to be alone in the room, but push the button, the machine waits 5 minutes, takes 3 readings, and gives you an average. And that is it doesn't get rid of all of the errors, but it gets rid of a lot of them. blood pressure determination that a lot of us have used historically is fraught with a lot of errors. It doesn't mean you can't do it correctly manually, but it's just more difficult. And if you use an aneroid manometer, it's likely not to be accurate anymore if it's more than 6 months or 12 months old unless somebody has checked it. So what medications do we have available to us? So in the United States, these are the classes that are available in at least most of the world. Diuretics, either thiazide type diuretics, I alluded to that earlier. That's what allowed us to do those initial trials starting in the 1960s and 1970s. Loop diuretics were often used more in heart failure, which you'll hear about more later, or in chronic kidney disease, particularly severe chronic kidney disease. Thiazides actually do work in chronic kidney disease more than we used to think. And there's some recent studies that show that to be the case. Potassium-sparing agents, which are not only beneficial to, for example, combine with the thiazides to allow the potassium to remain normal, but also they lower blood pressure. And we'll talk about that later, even though they're not usually recommended as initial therapy. And then the K-sparing agents are either aldosterone receptor blockers, ENaC inhibitors like pramipirine and Duralide, or the now what's not on the market yet is the aldosterone synthase inhibitors. And then there are the renin-angiotensin system blockers, and they certainly were an important part of our armamentarium when they started being added in the 1980s. We've got the ACE inhibitors, the angiotensin receptor blockers, and the direct renin inhibitor. I don't know if you have a direct renin inhibitor or more than one here. The only one I'm aware of that's come to the market is Listerine. And Listerine is actually not used very much, certainly not in the United States. It still remains expensive, even though it's not a very new drug, at least in the United States. It may not be here, but the main reason that it didn't catch on and wasn't marketed very much is because it was included in an outcome study in combination with an ARB. It was one of about 4 studies that showed that combining 2 RAS blockers is actually not beneficial, and it is harmful. It can lower blood pressure more, but it has no overall benefits on renal or cardiovascular outcomes, and it has some adverse kidney outcomes. The advantage to Listerine, if you do have it available to you, is that it's a RAS blocker that's very long-acting. So if you have patients that maybe or they admit that they're not taking their drugs every day, but they are taking them at least a few times a week, then once somebody's on it for a while, then it remains even for a couple of weeks before it gets out of the system. And then calcium channel blockers, the dihydropyridines and the non-dihydropyridines. We've done most of our outcome studies, not all, most of them using dihydropyridines, but there have been a few done with verapamil and diltiazem. And so guidelines do include any calcium blockers as part of the armamentarium, realizing that the dihydropyridines, and especially amlodipine, is the most common one that's been used frequently. The beta blockers, the alpha beta blockers, the alpha 1 blockers, the next class, simple alpha agonists, and so clonidine is the best example there. And then what's not on here, only because it's no longer available in the United States, is reserpine. So that's another adrenergic inhibitor. It actually was used, as I mentioned, in the VA cooperative study in the 1960s, and actually there's been a lot of research done. We did a number of studies in the VA in the States using it, and it seems to be better tolerated than a lot of the others if you're using low doses. As you know, in high doses it can cause depression, but 0.25 milligrams or less. And I don't know if it's available to you here in the fall, but it can be, again, practical because it's very long acting. So once somebody's taking it regularly, then if they skip some days, it may not make any difference. The direct basal arterial vasodilator, hydralazine, was in the original VA study, and it's still used a lot as an add-on if needed, if somebody's on several drugs and they still need something more. And I'll come back to that later. And then minoxidil is the most potent of the arterial vasodilators, and that also makes it a little trickier to use because it can cause volume retention, pericardial effusions, and you really have to monitor the patient very carefully, especially higher doses of minoxidil. unfortunately costs in the United States about $10,000 a year. And so I've actually never used it, and I've never seen it used, but it lowers blood pressure about as well as some other drugs as in resistant hypertension, but certainly doesn't replace so far any of the other drugs we're using for that. What I'm not mentioning today is the drugs that may come out soon, or or other techniques for lowering blood pressure, like renal denervation. And we just don't have time to go into that. They certainly can work. The one drug that is coming out will be a shot that's given every 6 months and lowers blood pressure a little bit more effectively than a single agent. And so we'll see if that gets approved and where that comes in our armamentarium. So there's no question that antihypertensive drugs changed cardiovascular outcomes once we started using them, as we tested in clinical trials, and then as we began to get more and more in practice in the 20th century. And particularly in the early 21st century, first decade, 2000s, at least in most places, blood pressure control rates improved considerably. They haven't continued to improve very much since about 2010, at least in many countries in the United States. But hopefully we can improve as time goes on as we learn how to use these. So what are the preferred classes to use, and why do we use them? Why do we recommend them? So in the 1990s, we started a study, the ALLHAT study, that was sponsored by the National Blood Institute, because in the 1980s, the only data we had on cardiovascular outcomes were with diuretics and with beta blockers. And beta blockers were not as consistently effective in reducing events as the diuretics were. So diuretics were the gold standard, and yet despite that, in most of the world, ACE inhibitors and calcium channel blockers were being prescribed more frequently than diuretics. And nobody had done a study, the FDA had not required companies to do a study to prove that their drugs, these newer drugs, were effective at reducing cardiovascular events, either as effective or more effective. And so, again, the NIH, National Blood Institute, initiated the ALLHAT study using ortholdone as the gold standard, 12 now 25 milligrams, and then compared amlodipine, as a calcium blocker representative, lisinopril is the RAS blocker. There were no ARBs when we started this trial, and doxazosin as the alpha blocker. And doxazosin wasn't used frequently as an initial drug, but a lot of the reason that people were saying you shouldn't use a diuretic or a beta blocker is because of some adverse changes in lipids and glucose. And they were very small, very trivial for the most part, but doxazosin, the alpha blocker, seemed to have some beneficial effects. And so it made sense to test them to see if, in fact, that led to a difference in cardiovascular outcomes. And so a very large study, 42,000 patients, and I'll cut to the chase and say that the alpha blocker arm was stopped early, as you may be aware or remember, after only about 3 years of follow-up. It was going to be a 4 or 5 year study. And the reason is primarily because in the last row here, cardiovascular outcomes were about 20% worse with the doxazosin. Heart failure was doubled or twice as common in the alpha blocker arm as the diuretic arm. And cardiovascular events in general were more with the doxazosin, not only compared to the chloralkali, but with the other 2 drugs as well. And so that arm was stopped. And ever since then, guidelines have not included alpha blockers to consider as initial therapy. Now, it's important to realize that when we get to the ones that are recommended, is that only a few other classes have been tested. Doxazosin, alpha blockers were one of them, and beta blockers were another. But all the other classes that we can talk about, besides the ones that have been recommended, have just not been submitted to outcome studies. And so that's the reason they're not included in the initial recommendations. Now, for the calcium blocker and amlodipine, there were a lot of published reports, mostly based on epidemiology, that said that calcium blockers were not only not helpful, they were harmful. And so there were reports saying they increased mortality compared to other blood pressure drugs. There were others that said they increased GI bleeding, increased cancer. And so calcium blockers in general, and we know this not only from all that, but from other studies, calcium blockers don't prevent heart failure as much. Now, the non-dilated periods for acrylonitazine are actually harmful in heart failure. Amlodipine may be pretty neutral, so it could be included in a blood pressure regimen, but not to benefit the heart failure per se. And so this was almost a 40% higher risk of heart failure. Now that's not as bad as no treatment or placebo, which would have been more like the doxazosin for heart failure, 100% increase in heart failure. And then the ACE inhibitor, which many of us predicted would be better than the diuretic or the calcium blocker, turned out to again not have any benefits in any of these outcomes compared with the diuretic. And I won't show the ACE inhibitor amlodipine comparison, but there were some differences, but overall they were both fairly similar in overall cardiovascular outcomes, but a little bit of differences benefiting calcium blocker and stroke, benefiting heart failure with the ACE inhibitor, which is now not such a surprise. But what we did see is that the heart failure was significantly worse, if you will, or not benefited as much by the ACE inhibitor. Again, it was probably markedly benefited because there would have been a doubling of heart failure that had no benefit. But it was not as much as the diuretic. And even combined cardiovascular outcomes and stroke were not as good with the ACE inhibitor as the diuretic. So when we then looked at the racial differences, in the black patients we saw that there was an even much bigger difference. And that drove a lot of the difference, the adverse effects with the ACE inhibitor. And then you can see, though, even in the non-black patients, there was still a 15% higher risk of heart failure. Not terrible, but some differences. So data like this has now been replicated in other studies after this. And that's why many guidelines, and some are dropping it, but I think it's still appropriate because of the outcome data, to say that black patients should not be started initially on an ACE inhibitor or an ARB unless they have another strong indication like nephropathy or HFrEF, for example. And so the heart failure, I'll just comment briefly. I'm not going to show the data, but what we saw is that the diuretic and the ACE inhibitor equally prevented low EF heart failure. So not treating those, but preventing those developing. And however, the diuretic is much better at preventing HFpEF. And so that was the big difference in the diuretic and the ACE inhibitor. And I think what that means is that they have very different mechanisms of action in how treating the hypertension is preventing the heart failure. And we hypothesize that putting them together, therefore, might be much better. And that, in turn, has been seen, in my opinion, for example, in the HIBET study, which used a combination of a diuretic and an ACE inhibitor. The heart failure has benefited even more than we've seen with other studies. So I think they're very good together in preventing heart failure, again, with different mechanisms. Sometimes we get biases in thinking that drugs are better or worse tolerated. It turns out that only 3 to 5% of patients overall on these three drug classes had to be withdrawn from the study because of adverse effects. And overall, there wasn't a lot of differences. You can see for unspecified, fairly similar for withdrawal for adverse events in general. The worst was the ACE inhibitor, but that was primarily cough, which is not a serious thing, but it's a reason to take them off and switch them at least to an ARB. The ACE inhibitor didn't control blood pressure as well. The yellow bars under elevated blood pressure, and slightly more lab abnormalities with the diuretic. But it wasn't real frequent. Even with 25 milligrams of chlorothalidone, we did not see a lot of hypokalemia, a lot of hyponatremia. And we see even less when we combine a diuretic with RAS blockers, for example. Now, the hyponatremia, I will mention, we've seen consistently across a number of trials where 2 to 4% of patients will develop significant hyponatremia and just have to be taken off of thiazides. There's not even that much of a dose effect where just going to lower dose will alleviate the hyponatremia. But fortunately, that's a pretty small percent of patients. I don't want to go into detail on this slide, but I just want to list all of the studies that were then done. What happened after ALLHAT, even during ALLHAT, the drug companies said, we better test our drug in an outcome so a lot of these were designed and funded by industry. A lot of them are very good studies, but some of them aren't because they used a comparator, the standard treatment, if you will, diuretics or beta blockers, that was not necessarily very effective. Because we already knew at this time that the beta blockers were not as effective at reducing cardiovascular events. So as you see, many of these studies use the beta blocker as part of the comparison. And if they used a diuretic, they often used a lower dose of diuretic than what we have shown to be effective in clinical trials. And so the studies in yellow are the ones that use appropriate doses of diuretic, and that's all had an insight. And in those studies, there's either no differences compared to the diuretic or diuretic and beta blocker, or as in all had, there was some benefit to the diuretic. Whereas in some of the others, most of them still didn't show a difference, but the accomplished study, which is often quoted today and given as a reason to not use diuretics as initial therapy, used a dose of hydrochlorothiazide of 12.5 to 25 milligrams, that in fact has not been shown to reduce cardiovascular events effectively. The target dose of hydrochlorothiazide that's been shown to be effective is 50 milligrams, and we'll look at that in just a minute. But it's hard to get people to use 50 milligrams of hydrochlorothiazide because, not based on data, experts started recommending using lower doses of hydrochlorothiazide, and that's why a lot of our combinations have lower than fully effective doses. So this is just a meta-analysis, one of many meta-analyses that has compared various classes of drugs, in this case to placebo or what there would be with placebo, sort of a network meta-analysis. And I wanted to point out a couple things. In the top left, the cardiovascular death, notice that the beta blockers are not effective compared to placebo in this meta-analysis. And we see the same thing, not quite as big a difference, but in stroke where the beta blockers are not as effective. And so those two things, and even looking at some individual studies, are the reasons that many guidelines don't recommend that we use beta blockers as one of our initial drugs in hypertension, unless there's some other good indication. Now, many people you're seeing do have a good indication for a beta blocker, and therefore it's appropriate to include it in the regimen, but it's important to realize that as the only drug in the regimen for somebody with hypertension, it may not protect them from mortality or from stroke, particularly in older people, as well as the other classes. So once somebody's on a couple of the more effective classes, then it's fine to add beta blocker. It doesn't have as much efficacy, and that's the reason it's not recommended to be routinely used, for example, as the fourth drug, routinely, just to lower blood pressure. What's not on here is heart failure. Now, in fact, beta blockers, not unexpectedly, do prevent heart failure as pretty well. And so they're pretty good looking at compared to diuretics and ACE inhibitors, but they don't protect from those other outcomes. And in fact, diuretics would look, and often do in that analysis, look much better at preventing heart failure. So that's why the ACC/AHA 2017 hypertension guidelines and many others say when you initiate drug therapy for hypertension, then for the most part, we ought to consider using either thiazide diuretics, ACE inhibitors or ARBs, not both, or a calcium channel blocker. And when we start adding them together, then those are the first three, if you will, classes to consider as initial therapy. Now, I alluded to dosing. I think dosing is very important. Low dose of multiple drugs can be very effective, and there's some new products I think that will be coming out looking at that. But very often our patients need full doses, if you will. In Table 18 in the ACC/AHA guidelines, and in fact for some years now, most of the major guidelines have had good tables of drugs and what the appropriate dosage range is. And I think it's good for us to look at those, because if you just look at the product insert, for example, or what's been approved by the FDA or what have you, particularly for the older drugs, the dosing is not necessarily correct anymore. And companies have no reason with a generic drug to go back and get the FDA to change the dosing recommendation. So that's important to keep in mind, that it may be different. I think the diuretics and even beta blockers and some ACE inhibitors are important to realize the dosing may be different than what was initially So, a brief word about hydrochlorothiazide versus chlorothalidone. And some guidelines do, as does the ACCHA, do specifically recommend preferring drugs like chlorothalidone or in some guidelines indapamide. And there are two reasons for that. One is what's shown here, and that's the effectiveness of these thiazide-type diuretics. The other is that we have more consistent outcome data with them. But here we see that comparing even 50 milligrams of hydrochlorothiazide to what we now recommend as the maximum dose of chlorothalidone, which is 25 milligrams, we see that the orange bar is the chlorothalidone that's more effective for 24-hour mean, 80 p.m., daytime mean, or nighttime mean. Not all of them are statistically significant, but this is a very small study. And there are other studies that show that this difference is consistent. And what we often do in our hypertension specialty clinics is when somebody comes to us on a multi-drug regimen, and one of the drugs is hydrochlorothiazide or a thiazide-type diuretic, usually they're either 12.5 or 25 milligrams of hydrochlorothiazide. Then rather than going up to 50, which would be an appropriate thing to do, then to switch them to chlorothalidone 25 milligrams. You could do the same thing, switching to indapamide. And so especially at night, the chlorothalidone is more effective. And both chlorothalidone and indapamide are very long-acting. Chlorothalidone lasts 2 to 3 days, whereas hydrochlorothiazide doesn't even last 24 hours in most patients. So we often accept it as once-a-day therapy in multi-drug regimens because those other drugs kind of make up some of the difference. If the patient's blood pressure is not controlled the next morning before they take the medicines, then consider switching them to longer-acting medications. So what I mentioned the racial and ethnic difference in recommendations here, and I won't belabor them, that not starting Black patients on an ACE inhibitor ARB is the only therapy, but certainly you can if they've got a strong indication for the RAS blocker, or it's fine to add it on in therapy in Black patients. And then 2 or more medications are recommended to achieve blood pressure target of less than 130 in most adults with hypertension. And I think this is illustrative of the data we've seen. We've seen the same thing in large clinical practice settings, that if you want to control 75 to 80% of your hypertensive patients, in this case, even to less than 140 over 90, then only about a quarter are going to be controlled with one drug. Only about 50% are going to be controlled with 1 or 2 drugs. And therefore, at least 50% of adults are going to need 3 or more drugs to control their blood pressure. And if your goal is lower, 130 over 80 or 20 or something, then you're going to need even more drugs. And so every patient I see, as a new patient, I explain this to them so that they don't think there's something wrong with them or the drugs or me if they have to get on more drugs. And many patients come to me trying to get on fewer drugs, which sometimes we can do because we can put them on better drugs or single pill combinations or more effective drugs and get them on less drugs. But I still try to prepare them for the fact that many patients are going to need more drugs. And I do try to keep it as much as possible as once daily therapy, and again, using single pill combinations, which I went into. So here's the way the guidelines put together. This is figures not necessarily in the guidelines, but basically saying what I've said, that starting with either thiazides, RAS blockers, or calcium blockers, and then once you start adding and going to 2 or 3 drugs, then that's what's considered the favored classes to use. And then resistant hypertension would be when you've used all 3 classes and you've got people on the full doses of various drugs or whatever they can tolerate, and they're not controlled, then they're considered to have resistant hypertension. Now, a beta blocker, certainly as I've alluded to, is appropriate in the regimen if there's a good indication for it, but not so much for the blood pressure effect. And then many guidelines have been recommending if the blood pressure is high enough that you think they're going to need at least 2 drugs to control their blood pressure, and the figure that's given in many as here is 20 systolic or 10 diastolic above whatever goal is going to be, then it's more appropriate to actually start with 2 drugs. Doesn't have to be in full doses, and there's good data that starting with 2 drugs is going to make it more likely that you're going to get the patient on a regimen that controls their blood pressure. Not, you theoretically couldn't do it adding one drug after another, but it takes so long to do that. It's much more expensive to do that, and patients will often bail out before we get to that. So, I want to comment on single pill combinations. I think you have a lot of single pill combination drugs available to you, and I was involved in a meta-analysis a few years ago where we showed that particularly for adherence and persistence of taking the drugs, like after 6 months or a year, what have you, patients are more likely to be on the medications and they're more adherent with them. That you see that with single pill combinations. In these controlled studies where the investigators were tightly controlling the therapy, if you use the separate drugs, then you still could get to the same place in terms of controlling the blood pressure. But often, again, the patients weren't consistently adherent. But observational data out in the real world shows that a year after somebody started on 2 or 3 drugs separately versus a single drug pill combination, they're much more likely to be taking the medications, and the blood pressure is better when they take those single pill combinations. So that's important. Now, through these various trials we've done, we've gotten good experience in how to get to these blood pressure goals in such a way that most patients tolerate it pretty well. And so I just want to briefly describe to you what we did in SPRINT. We monitored blood pressure every month for 3 months, and then we saw them less often. There is some data that if you follow up hypertensive patients every 6 months or every year, then they're much less likely to remain in control and to remain on their medications. We don't always have the luxury of seeing them every 3 to 4 months, but it's something to keep in mind. Lifestyle, as I mentioned, was recommended for everybody. And then antihypertensive medication titrations were based on properly done blood pressure measurements. We used fully automated blood pressure machines ever since 2004 and then SPRINT. And then a structured step care approach, but often starting with 2 drugs, use good classes and good medications. At the bottom here, we started the intensive patients in virtually all of these studies on a minimum of 2 drugs, even if their blood pressure wasn't that elevated. And there are a lot of good studies, even just for registration studies to get combination drugs approved, putting even not very elevated blood pressure patients on those combinations. They tolerated them actually very well. And the last thing is that we saw them every month and kept titrating medication or adding drugs until the blood pressure was under control. Now, where did the blood pressure go? I mentioned the average was about 120 systolic in the SPRINT study, and actually in several of these 120 goal studies. But you can see the black bar is after therapy, where did they end up? And the largest proportion were in the 110 to 120 range. We still have a lot in the 100 to 109 range. And by and large, these blood pressures were very well tolerated. We even had some below 100, not many. But what we would do, we didn't specify that investigators back off the therapy if the blood pressure got below 90 to 100, but virtually all of us did. We didn't want to leave them down in that range. And as I indicated earlier, for the most part, patients I see that have consistent symptoms with low blood pressure are when the systolic is below 90, or treated below 90. We actually got 62% of the 120 goal people below 120. We got 80% of them below 130, even though the goal was 120. So if your goal is 130 and you control 80% of your patients below 130, then you're probably going to get about what we got in the SPRINT study. And so I think applying the guideline, and if you're monitoring how many people you control, then that ends up with similar kind of results. We use more of all the drugs than in the intensive and the standard group, but they were the same drugs in the same order. RAS blocking agents, ACE-ARB, diuretics, calcium channel blockers, and even beta blockers. But we did have a lot of patients with known coronary disease or cardiovascular disease in spring. So this is just what I said, that based on all these studies, the best thing to do, unless the blood pressure is really severely elevated, is to bring people back on a monthly basis until the blood pressure is under control, or you and the patient have agreed this is where we're going to stop. Now, I mentioned, what do you do with resistant hypertension? Once you've got them on all three classes, then the next thing to do would be to add spironolactone in the guidelines. And it's based predominantly, not only, there are several studies, but predominantly on the Pathway 2 study that was done in the United Kingdom. And what they did is they took people on triple therapy, that I've already alluded to, and they still weren't controlled, and they randomized them, and they cycled them through these various periods where they're randomized to either spironolactone, 25 to 50, doxazosin, lasoprolol, beta blocker, or placebo. And then I'll talk briefly about, after that, they put them all through an amiloride arm. So, and what they found was that spironolactone was just clearly more effective. And I won't go into details, but clearly, and this has been consistent in several studies, this is the most effective single drug, at least in tests, to get the blood pressure down. And I think I'm not going to talk about this individually. However, there's some data that amiloride is pretty good. And this was a study that essentially showed that amiloride at 10 milligrams was more effective than spironolactone at 25 milligrams when added to other drugs in uncontrolled hypertension. But that's probably not a fair comparison. So we usually use 25 to 50 of spironolactone, and often we only use 10 of amiloride in the United States, but you can use higher. In Europe, they often use 10 to 20, and I often do too. And what they did in the Pathway 2 study is that the amiloride arm was kind of the last arm that everybody cycled through, and they showed that the amiloride and spironolactone were equally effective. Spironolactone 25 to 50, or amiloride 10 to 20. And that's good to know because a lot of our male patients just can't take spironolactone on a long-term basis. It's pretty well tolerated in the study. They were only on the medication for a few months, and a lot of the endocrine effects occur much longer term than that. And so amiloride is just as effective. So there are a lot of other drugs that we can include in the regimen, and so I just list them here. I already mentioned spironolactone or amiloride, which I think are the preferred drugs to add forth unless there's some kind of medication or they're not tolerating it. Certainly somebody who already is predisposed to hyperkalemia or has significant renal dysfunction, chronic kidney disease, may not want to use it in those patients. I mentioned reserpine, which we don't have available to us anymore in the United States. You may, and certainly you can be an appropriate adrenergic inhibitor to add, but not as one of the first three classes. Alpha blocker, particularly if the patient has BPH, urinary problems. An alternative calcium blocker. So there's good studies that show that if you add a diet period and non-diet period together, you actually do get more blood pressure effect. What you don't want to do in most patients is add a non-diet period to a beta blocker. So you have to be more cautious. The non-diet periods also have more drug-drug interactions. So we don't, use them routinely in preference to the diet periods. Vasodilator, hydroxyl minoxidil that I mentioned, alpha-beta blocker, carvedilol is probably used more often, but labetalol is still used often. And again, most of these are fourth or fifth line drugs. Central agonists like clonidine or guanfacine, which is a little bit better because it's longer acting. And then the new endothelin antagonist, aprocitentan, which, as I said, is effective. It's never been compared head-to-head to spironolactone or amiloride that I'm aware of. I've not seen any studies on that. And I would doubt that it's any better. It is approved in resistant hypertension, but as I alluded to earlier, it costs in the United States about $10,000 a year. And so it's just, so far, it's just not used. And I don't see any big advantage yet to it, even though eventually if the cost comes down, it may be something that we can consider in our regimen. So we come back to this patient, and since you answered for the most part correctly, won't belabor the fact that her cough led you to change the lisinopril to an ARB, and then she wasn't controlled, and so adding the chlorthalidone or some diuretic would be appropriate because she's already on a calcium blocker and a RAS blocker. So I'm not going to go through the question again. So, pearls of wisdom. Just to repeat, encourage recommended lifestyle changes with any drug treatment. There are 4 major classes of drugs, but you can think of them as 3 major classes to use as the first 2 to 3 classes in most patients because they are the most consistent cardiovascular outcomes, are well tolerated, and effectively combine well together. And then most adults with hypertension will need 3 or more medications to control their blood pressure and to meet blood pressure goals. And single pill combinations can be a real advantage, particularly if they're not real expensive and can improve adherence, persistence, and at least in clinical practice settings have been shown to also improve blood pressure control, which makes sense. The patients are more adherent and they're more likely to take the medications. And then spironolactone or miloride, if there's not a contraindication, are best to add as the 4th agent in resistant hypertension. Again, there are a variety of other agents that can be added. Should not be preferred early in the therapeutic regimen. So thank you very much for your attention. I'd be glad to discuss it with this.
Any questions?
We get a lot of electrolyte imbalance with thiazides, especially the chlorothalidone. We get a lot of electrolyte imbalance with
My
thiazides.
hearing aids, the speaker's going out, I can't hear. Yeah, so electrolyte imbalances, as I mentioned, about 2 to 4%, and it's more frequent in older age, about 2 to 4% will develop hyponatremia recurrently. There are rare cases where somebody may get sick, still take their thiazide and get hyponatremia. But there's some people that are just going to get hyponatremia. It's not very common, but if they get it, that's why we should get it. And I didn't mention this, that anytime we start a diuretic or an inhibitor or an ARB, and within the next several weeks to a month, it's good to check at least creatinine and potassium. And so you certainly get a combined panel of electrolytes. So there's a small percent that does occur, but fortunately it's not really common. And the other thing is that hypokalemia is much less common in our studies, even the ALLPAC study where we weren't adding an ACE inhibitor or an ARB2. We saw it less commonly when you add an ACE inhibitor or ARB, or certainly spironolactone miloride, then you can offset it. But it's not very common, and particularly if it does the thiazides. I mentioned the APQFP study. They actually use 50 to 100 milligrams of chlorthalidone, and they definitely had more hypokalemia. I can't remember how frequent it was because that was 40 or 50 years ago. But even then, mortality was reduced more, even with a high dose chlorthalidone. So the hypokalemia probably isn't that severe, but if something does develop it, then we should look for primary hospital in that patient, even if it's thiazide-induced hypokalemia.
Sir, how do you see a challenge in managing hypertension in CKD patients on maintenance and hemodialysis?
CKD,
Under maintenance hemodialysis.
Yeah. So I'm not.
And the target?
So I'm not a nephrologist. I will say that I mentioned earlier that thiazide diuretics actually work at lower GFRs than we used to think, but not certainly in stage 4 or 5. We wouldn't use it routinely. In dialysis patients, what happens is that once the GFR gets below about 30 or so, then I do refer the patients to a nephrologist to take care of them. I think a nephrologist needs to manage those patients that are nearing dialysis because even though the ACE inhibitors, ARBs appear to be beneficial in preserving renal function at those lower GFR levels, they can make the numbers worse believed to be put on dialysis early. So that's why I think the nephrologist needs to do that. In terms of patients on dialysis, I have to admit I don't have experience. The guidelines don't address that. Even the KDIGO guidelines that I'm aware of, I was part of that in managing hypertension and chronic kidney disease. It didn't include patients who are on dialysis. Many of the drugs can still work. Obviously, the diuretics should not be very effective. The difficulty with a non-nephrologist managing a patient who's on dialysis is that the dialysis itself can be very effective at treating and lowering the blood pressure. If their blood pressure is lowered too much prior to going, into the dialysis treatment, then their blood pressure can get too low. So the nephrologist needs to manage that. They may, I'm not sure exactly what they do, but they may not take off as much fluid, for example, if the blood pressure changes.
Yeah, that's the major point I wanted to discuss with you, sir. Because the post-dialysis, because the hypertension as per se in CKD patients are due to the flu dynamics. And post-dialysis, the same antihypertensive that we keep on continuing lowers down the blood pressure drastically. So, do we need to address, because these CKD patients usually we see thickened, non-compliant, left ventricle with dilated area, with mild pulmonary hypertension, because the hypertension is not controlled at any point of time in these patients. So, I think we need to think about it and make a guideline regarding management of hypertension in these CKD patients as well, where we can choose short-acting drug, making it an off day for a drug on the very dialysis day, so that on an average we can get a better blood pressure control.
Yeah, well, thank you. Very, very good thought. There are many times for considerations where we may have to modify our therapy. For example, if we have patients that are running in long distance races, they're not just during the training apparently, but on a race day, I actually recommend, and that was taught to me by somebody who treated a lot of patients who were running marathons, is to not take their medications on race day. And so the same thing, medications may have to be adjusted in patients on dialysis, as you said, pre and post dialysis, and that's why I rely very much on the nephrologist to do that. I'm not trying to.
Thank you.
Thank you.
Okay, sir. Actually, we are facing problem with the post-gestational women. Post-gestational women and breastfeeding mother. What will be the recommended drug of choice for hypertension?
Yeah. I would, so two things. One is that in general, women of childbearing age should not be on ACE inhibitors or ARBs or RAS blockers, of course. And I don't treat hypertension pregnancy, and we don't address that in most of our hypertension guidelines. There's separate guidelines for that. But I think, so post, if they're breastfeeding, then I think I don't know off the top of my head which ones are not in the breast milk. I think you just have to look that up. So I apologize that I don't know the answer to that.
How safe is ACI and ARB in lactating mother? Safe, ACI and ARB.
Is ACE and ARB is safe in lactating mother or not? Is that
Are they passed? I don't know that, but we shouldn't use them in women with childbearing potential.
Almost all the drugs is antihypertensive, almost all drugs is passing through the veins. So how safe it is, I don't know. So what is the recommendation to this?
actually the guidelines says it is contraindicated during pregnancy. Somebody is lactating, then you can start. Yeah, after delivery, yes, you can. Thank you.
Thank you very much.
We'll move on with the tea break.
Good. Good, very good, very excellent.
I know, I was looking.